If you look at the diseases in congenital heart disease and pregnancy that we've dealt with here, so at Montefiore, I've been here now going on to almost 2.5, 3 years, and we've seen some spectacular cases here in Montefiore in the Bronx. One of the patients we recently delivered was a young woman who had what's called Marfan syndrome. So it's not a congenital heart disease per se, but it's what's called connective tissue disorders. This young girl was born with Marfan syndrome, and she had multiple aortic surgeries when she was a child, which basically means with Marfan's, the aorta dilates. So instead of being a normal caliber, it dilates. And that then puts you at risk of what's called dissection or rupture. And that's a very, very high risk. So they say Abraham Lincoln may have had Marfan's. That's correct. So it's a connective tissue disorder. So you're tall and thin and lanky. And the same thing happens with the heart, and same thing happens with the aorta. Now, this particular young lady managed to get pregnant, and she's had 3 open heart procedures. And when I saw her, she had a couple of open heart procedures. She was going in and out of what's called atrial fibrillation, so the rhythm was abnormal. She was 24 years old, and now you're dealing with pregnancy in a severely complex, high-risk patient, and we got her through that. So our program, we came together with the high-risk MFM. We got the anesthesia docs involved. She had spinal rods in her spine because her spine was not normally aligned. So she had multiple spinal rods. So giving her anesthesia in that area was not an easy process. So we had to figure out how we were going to deliver her, and then once we delivered her, how do we handle the rhythm? Do we anticoagulate her because she's had abnormal heart rhythm? So she did very well. We actually had her on blood thinners because of the risk of atrial fibrillation forming small blood clots. So now you've taken a young woman with 2 or 3 open heart procedures, who has an aorta that has been repaired, was dilated and has been repaired, who has spinal rods in her spine, and you have to figure out anesthesia, and then it's going in and out of an abnormal heart rhythm while all this is happening. So you have to put all that together, and so it's a very fascinating case, and she did very well. She just had a child, and she's doing very well. We just recently saw her. So that's one case that we've seen. I'll give you another example of another fascinating case. Again, you see all sorts of things in the Bronx. There's a young lady we just met who is also 24, and she walked in pregnant, and her oxygen saturation that her doc did out in the clinic was 75%. Now, normal oxygen saturation should be close to 100%. She was 75%, and she was, lo and behold, she was pregnant at a saturation of 75%. Very quickly, she was in my clinic, and we took a look, and we did an echo, an ultrasound of the heart, and she had very complex congenital heart disease, which is basically what's called a double inlet left ventricle, which in essence again comes down to basically a single ventricle that is giving blood to both the lungs and the body. And that's called a double inlet left ventricle. And she was, when I saw her, she was about 24, 25 weeks pregnant. So again, very, very complicated case. Getting our high-risk colleagues together, we made a plan as to how we should deliver her. She's another one we had to think about anticoagulation. There's a risk of blood clots that could go from one side to the other. One of the dilemmas of congenital heart disease is that these young patients, if you think about it, they're all young, who are in their 20s and 30s, maybe into their 40s, were born with congenital heart disease. This is what they were born with. They had surgeries when they were children. I see patients who are 24, 25 years old with 2 or 3 open heart procedures. What happens with these patients is that they, as they grow from the world of pediatrics, from the world of children to the world of adult cardiology, there comes a time which is called transition, which means they should be appropriately transitioned from this world of pediatrics to the world of adult internal medicine, adult cardiology. And a lot of these patients, unfortunately, either get lost to follow-up, so they feel they were fixed, they were repaired, we're fine, we're 18 years old, why should we have a problem? And they go out in the world, and at 26, they have an abnormal heart rhythm, someone has what's called a sudden event, and they very quickly show up in clinic. So do they know they're high risk? Well, they think they aren't, unless they've been through the process of transition, which is someone sat them down when they were 12, 13, 14 years old with mom and dad and said, listen, you've had multiple open heart procedures, you will remain at risk of something going wrong down the road. And that's what's called transition. Unfortunately, nationally in the United States, transition is done very poorly, and it should be done much better. Not just in the world of congenital heart disease. You take any childhood illness, be it congenital heart disease, let's say cystic fibrosis, childhood cancers, childhood autoimmune diseases, right, like rheumatoid arthritis or lupus or things. These kids are growing up. Medicine has come a long way. These kids survive. They get into adulthood. And what happens is, if they're not transitioned, they either don't understand their risk, or they get lost. And then they show up pregnant, or something happens, something goes wrong, and someone says, hey, listen, you had 4 open heart surgeries. You need to see an adult congenital specialist. And that's unfortunately what happens with these patients.